Sir, you can begin, sir. Pratap, sir, you can begin.
Such a lovely introduction to me and to all your, the series team that you guys have involved in making this, the lectures available to a lot of people, not just in India, across the globe as well. And it has been a stupendous effort from Dr. Abhishek, Praveen Venkatgiri, Dr. Srinivas Murthy, and at the outset, I would like to thank you all. So I was asked to talk about inhaled nitric oxide in the treatment of pulmonary hypertension in term babies. What I also thought was basically if I just start with that, it is going to be a little bit of a nightmare because it's like starting from nowhere. It is like the tail ender coming to open the batting. So I thought I would start with a little bit of fetal and transitional circulation introduction to you guys, pathophysiology of how your pulmonary hypertension starts and establishes itself, some of the causes of it, and how do you broadly manage pulmonary hypertension before going on to the actual nitric oxide part of it. So thank you very much, everybody, for answering those questions. In fact, I had different, slightly difficult questions than what Abhishek had posted. Looks like you guys are all already punters in it and in this, and I don't think you need to, listen to lectures like this answering those questions. Anyway, without further ado, I just would like to continue. Fetal circulation. So I will use this pointer to navigate through this. What is fetal circulation? By now, you must be all really aware of it, and a lot of webinars have taken place on pulmonary hypertension. So fetal circulation starts from what I call as this placenta. Placenta is the most important organ which has got a high capacitance and a very low vascular resistance. From the placenta, mommy sends all the blood through the umbilical vein, and which goes through, gets itself into the right atrium. The way the way the flow of the blood is directed, majority, almost 70% directly enters into the left atrium through the foramen ovale. And the foramen ovale is designed to open towards the left atrium. That is anatomically and physiologically, that is how it is designed. So the blood enters your left atrium, comes to the left ventricle. Mind you, all these are oxygenated blood. And then through the aorta, it gets mainly supplied to the brain and all the rest of the parts of the body. And the remaining 30% of the blood also gets into the right ventricle. From the right ventricle, gets into the pulmonary arteries, and it can supply to the lungs as well, right? So all the deoxygenated blood comes through to the lower end of the aorta, and then through the umbilical artery, gets back to the placenta for reoxygenation and getting itself more nutrients along the way. So this is basically fetal circulation in basic, right? So there are a couple of shunts here which are very important, without which the babies won't survive inside. And one of that shunt is intracardiac, which is your patent foramen ovale. If the patent foramen ovale is, if it's not patent and if it closes, then it's not a good sign. Then the second one is your shunt, which is outside the heart, between the pulmonary artery and the aorta, which is your ductus arteriosus, right? So as we go along, I'll tell you the importance of these. Right. So what we need is a very smooth transition from the fetal life into the extrauterine life. So this is what we all expect. The baby should come out crying and kicking, and then the baby should get back to mother for breastfeeding initiation. So however, life is not that easy. But on the other hand, some of the mechanisms should happen before we say the baby is fit to get to the mother. Say here in one of these slides, mind you, I'm going to use lots of the graphs as well as some of the amazing pictures. These are all from Dr. Satya et al. And their group for doing unbelievable work on pulmonary hypertension. So none of this is mine. That's the disclaimer. I'm going to use majority from Dr. Satyan and group, and some from other resources as well. So here, this is a graph which shows your pulmonary, your main arterial pressures on the y-axis, and the time taken, age in the minutes on the x-axis. When you look at it, there are three important parameters depicted here. Number one is your, in blue, is your systemic arterial pressure. If you look at it from the fetal birth or just before that, your systemic arterial pressure is lesser compared to the pulmonary arterial pressure. The reason is the lung is full of fluid, and then the vascular resistance is higher in the lungs. And also, if you look at the last one, the red one, where this is the pulmonary blood flow. The pulmonary blood flow is very less, and the pressure is also very less at that point in time. And the pulmonary arterial blood flow will increase at the time of the birth, right? And at the same time, your pulmonary pressures gradually starts decreasing. It will take, in some instances, up to 3 months for the pulmonary arterial pressures to normalize. And systemic arterial pressure goes up just after the birth. How does it happen? It happens, one second, sorry, I missed it. So it happens based on the clamping of the cord. Remember I said placenta is a very low resistance system. So when you clamp the cord, the systemic resistance increases dramatically, and then your lungs will start to be filled with oxygen. Therefore, the pulmonary vascular resistance starts decreasing in the lungs. So increasing in the systemic arterial resistance, decreasing in the pulmonary arterial resistance. Plus, there are some other cyclical AMP and cyclical GMP related pulmonary vasodilatation. All this happens just at the time of birth and just after the time of birth, right? So this plays a very, very important role in a smooth transition of fetal to postnatal life for the babies. Then you look at the transition. First of all, you need a rapid fall in the pulmonary vascular resistance, followed by increase in the pulmonary blood flow. We all saw that. And enhancing the pulmonary venous return. When the blood flow is more, venous return is also more. When the venous return is more, what happens? Your left atrial pressure goes up. When the left atrial pressure goes up, obviously, there is a functional closure of foramen ovale. You must remember that the foramen ovale opens towards the left side of the atrium just by physiology and anatomy. Now, when the left side blood pressure is more, it tends to close. That's a functional closure of foramen ovale. And then blood through the PDA starts reversing to left to right. Some of these are mediated by nitric oxide related cyclical GMP and prostacyclin related cyclical AMP pathways. I'll tell you in detail in about a minute. Then overall, there is a decrease in the influx of the intracellular calcium because of all this mechanism that results in a pulmonary vasodilatation. So this is in a nutshell what happens just after birth and giving a smooth transition to the baby. So when you look at this, this is another slide depicting the various stages of respiratory development through the fetus from 20 weeks onwards until the postnatal age group. So if you see, the lungs are very, very simple to start with. Just about the canals start coming up. That will become a little bit of saccular. So you enter into the saccular stage of development in the lungs, followed by alveolar stage. Friends, when you look at it, the alveoli stage just around 36 to 40 weeks of gestation, and it carries on up to 2 years of life. So imagine a baby, you look at his blue line, that shows your pulmonary vascular resistance actually is at the highest just before the birth, which means is at the highest, it's around 36 to 40 weeks of gestation. Therefore, don't just think that it is going to be okay to be born as borderline prematurity. It is not. pulmonary pressures are very, very high. And any problem during the time of delivery, if it is not smooth, say for example, the lungs are not primed for it, right? Majority of your blood in the lungs is absorbed using the hormonal mechanism. This when the baby is born without being in labor, that absorption of the fluid is hampered to a little bit. That is what is called as the TTN. This predisposes to pulmonary hypertension. Or if there are other parenchymal lung disease, for example, the baby has passed meconium and then had meconium aspiration, or if the baby is born with congenital pneumonia, or if the baby has got significant surfactant deficiency, whether it is because of primarily surfactant deficient at birth. These factors results in vascular. Then if you see after the birth, your pulmonary vascular resistance should really, really fall, and correspondingly systemic vascular resistance should go high. I hope you're with me so far. Then moving on, what happens now? All hunky-dory stuff, whatever I described, if it fails to happen, if there is a failed pulmonary vascular transition at birth, it results in pulmonary hypertension with shunting of deoxygenated blood across the two important shunts, the ductus arteriosus outside the heart and the foramen ovale inside the heart. Then this results in severe hypoxemia because your blood is going from right to left. What does this lead to? Severe pulmonary hypertension. What does this further lead to is a total circulatory failure. And if no treatment is given, babies will not survive from this. So this is what I wanted to talk about, the physiology. And moving on, I would introduce some of the etiology or the causes of pulmonary hypertension. See, one of the commonest cause is idiopathic, which means we don't know why this has happened. You know, this is called persistent primary pulmonary hypertension, or persistent of fetal circulation is another term that can be used for this. When you have parenchyma involved, you can have, as I suggested, TTN, because the lung fluid is not absorbed that well, which will hamper the production of the surfactant and therefore increased pulmonary vascular resistance. Other parenchymal conditions like the pneumonia, like meconium aspiration syndrome, respiratory distress syndrome because of surfactant deficiency, or you can have severe pulmonary hypoplasia secondary to your congenital diaphragmatic hernia, or some cases where mom has taken in aspirin during her pregnancy that can result in premature closure of the duct. That can also result in very significant refractory pulmonary hypertension, right? And also nowadays we see more and more birth asphyxia. Birth asphyxia in itself causes severe pulmonary acidosis as well as pulmonary increased vascular resistance. So all this will worsen the pulmonary hypertension. And these are some of the causes of pulmonary hypertension. So I will give you a little bit more detailed version of this when you look at the pathophysiology. It can be easily divided into 4 different mechanisms. Again, all of this is taken from Dr. Satyan and group. They've done wonderful work on this. Nothing is my own work, okay? So when it looks at the pathophysiology, it can be divided into intravascular obstruction. So you have an obstructive pathology, most commonly because of hyperviscosity syndrome. Again, that is due to what is called as polycythemia. That is due to polycythemia. Severe polycythemia is also one of the reasons why you develop pulmonary hypertension. There is another entity called maladaptation. The baby has not adapted that well to your circulation. And this results in acute vasoconstriction. Some of the examples are pneumonia, sepsis, meconium aspiration. Again, here meconium aspiration and pneumonia also causes secondary surfactant deficiency. Then it leads to severe and acute vasoconstriction. The other important pathophysiology is your maldevelopment, or where your vasculature, the pulmonary vasculature, is completely remodeled. This happens in diaphragmatic hernia. and sometimes chronic intrauterine hypoxia. Chronic intrauterine hypoxia, we had a recent case where the hemoglobin at birth was about 3.8. This was due to chronic fetal-maternal hemorrhage, which we detected. I'll show you in a slide later. And sometimes also because of antenatal ductal closure, as I suggested, because of inadvertent usage of the aspirin. Then there is another big entity where it is underdeveloped. And this is usually causes pulmonary hypoplasia. Some of the examples of this is diaphragmatic hernia, where your lungs are not developed at all. Why it is not developed? All your, the content of the abdomen is sitting inside usually the left thoracic cavity and compressing the lungs. Thereby, there is not much circulation of the amniotic fluid, and you develop smooth muscle hypertrophy in the vasculature, right? This mechanism is very similar to your chronic oligohydramnias. Again, I'll present that case where we had a baby from 23 weeks onwards without any liquor, but delivering that baby at 23 weeks causes more danger than keeping that baby in utero. So the baby was delivered at 29 weeks of gestation, and the baby had severe refractory pulmonary hypertension. Again, it could be because of renal dysfunction. One of the examples could be your Potter syndrome, where this complete renal agenesis resulting in severe oligo or anhydramnias, which will impair your vascular bed, and that can cause pulmonary hypoplasia. So this is how we can easily divide it, and in each one of them, the management aspect can be different. Therefore, I would like you to concentrate on this slide and make sure you understand this, because the way that you manage these babies might be different, right? Moving on. So you have a baby who's been diagnosed, who's been born, and then this baby, we suspect this baby has got pulmonary hypertension. So how do you diagnose this baby clinically? So firstly, history. As I suggested, whether there is any history of sepsis in the mother, whether there is any history of meconium aspiration, whether there is any history of aspirin ingestion. So, or antenatally that that there is a congenital diaphragmatic hernia. So all this is extremely important. Therefore, anytime you go on attended delivery, you should know about the history of the mother, including the medication history. Then you look at it, the baby is born. Generally speaking, majority of these babies have significant respiratory distress. Why? Especially if it involves the lung parenchyma, wherein you might have meconium aspiration, therefore you're struggling. You might have pneumonia, therefore you're struggling. You might have a diaphragmatic hernia, that is another reason for respiratory distress. And it just doesn't have respiratory distress, it also presents with cyanosis. Okay, when you look at the saturation, that's one of the very important things to be used in clinical diagnosis of pulmonary hypertension is look at the pre and the postductal saturations. Pre is your right hand, right? And post can be any other limbs. Generally, diagnosis can be achieved if it is 5% or more difference between pre and the postductal saturations. However, it is almost confirmed that more than 10% is associated with definite pulmonary hypertension. So this is the saturation which is put in the foot, and this is postductal saturations. And generally, when your pulmonary hypertension is there, pulmonary venous return is very poor. Therefore, your cardiac output is very poor, because what blood returning back to the heart is also less. Therefore, you can develop poor perfusion, which will be seen by capillary refill time should be more than 2 seconds. And as I suggested, your you can sepsis, you can have severe metabolic acidosis. You can, if a baby is born with diagnosis of blood pressure. So it is very, very important to have arterial blood gas.
Close your video.
Who should I?
Can you close your video? We have some problems with the network. Can you switch off your video?
Should I switch off?
Yeah, you can switch off your video.
Okay.
There's some problem with the network.
Is this okay now? Abhishek, is this okay? Can I continue?
Ha, sir. Please continue, sir.
Okay. Sorry for that. It's always the technological glitches. And in some cases, when you want to do an ECG, then you will see right ventricular dominance and ST elevation. I'll tell you why all these things happen. So moving on. So chest X-rays again forms a very important role in the diagnosis. And I'm so sorry if the images are not well projected. The first one is your idiopathic pulmonary hypertension, or sometimes we call it as the black lung or the dark lung, where almost no blood is entering into the lungs, which can cause severe hypertension. The second picture here on the right shows, not ground glass. It shows patchy opacification in both sides of the lungs, which is typical of meconium aspiration, along with over distension and areas of collapses. Then you have severe pneumonia, where it can involve just one lobe, or it can be viral pneumonitis as well, involving both the lobes as well. And our good old congenital diaphragmatic hernia, I don't think it's projecting that well, but this is some of the, the abdominal contents have herniated into the left side of the thorax, causing pulmonary hypoplasia. Doesn't look like the liver is herniated, but then in here, maybe you need to do an ultrasound scan to confirm the diagnosis of being present in the chest cavity or not. So moving on. Whatever it is, echo forms the gold standard in the diagnosis of pulmonary hypertension. Why do I say this? Basically, it is helpful to establish the diagnosis of pulmonary hypertension, number one. Number two, it will also rule out your cyanotic congenital heart diseases. I should say one of the examples where I was finishing my night in UK, working as the final year grid trainee registrar, and we had a baby who came out completely blue. And then I was learning the echo at that point, and I had done more than 200 echoes by then. Because I was so tired, I really wanted to do the echo quickly, finish it off, and then head back home with a diagnosis. When we did the echo, I saw what I wanted to see, which is a very significant, severe tricuspid regurgitation. The mind stops there. And I said, there is a very severe hypertension, pulmonary hypertension. You carry on and you start, with your treatment of nitric oxide and the rest of it. So when we said that, the baby did not improve after starting the treatment. So it is extremely important, again, you need to revisit it. You need to revisit. When they revisited, it turned out to be actually a TGA with an intact septum. Why did they revisit? Because the baby's condition wasn't improving, right? So it is important that you just don't do one echo and then leave it, but then echo should be done by an expert or by the cardiologist to rule out cyanotic congenital heart diseases. Then, echocardiography is also very, very helpful in assessing the ventricular functions. I'll tell you why ventricular functions are important. Because in order to choose the type of management, in order to choose the type of inotropes and the vasodilators, your ventricular functions are extremely important. Then, echocardiography is also very important in assessing your pulmonary pressures. So once you know what the pulmonary pressures are, it will be able to guide you in the treatment modality. Also, it will be very useful for you to keep checking the pulmonary pressures by doing echoes once every day, so that you will know whether you're improving or whether you're actually getting worse conditions. So echo forms the gold standard. So again, this slide has been represented by Dr. Satyam Lakshmi Narasimha. Again, basically, it is a pictorial representation. I will just take you through this. First of all, if you look at the heart as a four-chambered view, you will see the the bowing of the interventricular septum towards the left. So it is because of increased right ventricular pressure. And when there is increased right ventricular pressure, there will be significant tricuspid regurgitation as well. And with that tricuspid regurgitation, blood tends to flow into the patent foramen ovale as well. Then when you look at outside what is happening, whatever the blood is going through the pulmonary artery, because the pulmonary artery pressures are very high, it is getting into the aorta as well, resulting in a right to left shunting. Therefore, the shunting is right to left in PDA as well as pulmonary patent foramen ovale. Then you also have to look at the left ventricular function and the output. The right ventricular function as well should be looked at, including the output. So once you have all these, then you can also look at the tricuspid regurgitation. What is the velocity of tricuspid regurgitation? So this is the echo, which shows there is a continuous wave Doppler that is put in across the flow of the tricuspid regurg. And then whatever you get below this line is your velocity across the tricuspid valve. And based on the velocity, the pressures can be calculated using the standard formula. So this baby has got a significant tricuspid regurgitation. Then you have all this information and you need to calculate the pulmonary pressures. How do you do that? One of the clues is if there is a right to left flow across PDA and PFO, then you know that the pulmonary pressures are very high. And this also is detected by the increased pulmonary artery resistance. As I showed you, you need to calculate the tricuspid regurgitation velocity using the formula. The formula is very simple. P, the pressure, is equal to 4 times the velocity square. Say, for example, if your velocity has come back as 4 meters per second, in this case, then your formula goes as 4 times 4 square, which will be 64 will be the millimeters of mercury will be the pressure. You need to also add the right atrial pressure to get the pulmonary artery pressures. Right atrial pressure, generally we take it as 5 to 6. So in this case, if your velocity across the tricuspid valve is about 4 meters per second, you're looking at your pulmonary pressures as almost 70 millimeters of mercury. Right. There are other ways of assessment of severity of your pulmonary hypertension and severity of hypoxic respiratory failure. One of them most commonly used and we use quite often is oxygenation index. What oxygenation index means is basically how much pressure is needed for you to maintain certain amount of PaO2 in blood. So this is calculated by mean airway pressure, which you will be looking at your ventilators to get the information, and times your FiO2. FiO2 is your fractional inspired oxygen, times 100, divide that by your PaO2 in millimeters of mercury. So it gives you the oxygenation index. There are other formulae that can be used where you're looking at the diffusion or the dissociation of the oxygen, which is used by the formula given here, which is the pressure of the atmosphere minus the water pressure times FiO2 minus PaO2 minus CaO2, divide that by 0.8, which is a constant that gives you the diffusion of oxygen. The other one that can be used is called the OSI, which is the oxygenation saturation index, where you look at the MAP times FiO2 times 100 divided by preductal saturation. So here you're looking at the saturation. In OI, you're looking at actual PaO2. So these are some of the parameters that are used to assess the severity of the pulmonary hypertension. See, when you look at the oxygenation index, again, this is taken from Dr. Satyan and co. when your oxygenation index, which is on the x-axis, and here on the y-axis is your percentage of incidence of ECMO and the death, right? When you look at the cluster of balloons here, each balloon represents the number of patients involved in the study. So the oxygenation index, if it is anywhere between 15 to 25, the number of survivors are very high, as well as the number of babies needing ECMO is very low. The survivors are very high, needing ECMO is very low if you're at an oxygenation index of between 15 to 25, which directly proportionally rises, the need of ECMO rises, and also the death rate also goes up if you start any treatment initiation beyond 25 to 30 of your oxygenation index. So that shows the importance that you need to be looking at it very carefully, the progress of the baby, as well as start things at the right time. So moving along, this is another busy slide, but it's a very, very important slide. I will just take you through very quickly because this forms the basis of our management. So if you see on the left-hand side, there is this prostaglandin, which helps in which helps in the conversion of cyclooxygenase using adenyl cyclase to convert it into cyclical AMP. This is one of the most important pathways, which is driven by the prostacyclin or the PGI2. What does cyclical AMP do? It reduces the calcium influx, therefore causes vasodilatation. So this is your smooth muscle cell. Then on the other hand, on the right-hand side, you have endogenously present nitric oxide, which with the help of endogenous nitric oxide synthase will work on your soluble guanylyl cyclate and results in the formation of cyclical GMP, right? So your cyclical AMP, your cyclical GMP, both are formed by different mechanisms, but both results in vasodilatation by reducing the influx of the calcium, right? What happens to cyclical AMP and GMP? It further becomes AMP or it further becomes GMP respectively by phosphodiesterase 3 enzyme or for phosphodiesterase 5 enzyme. So both these enzymes can be inhibited by using medications. One of the powerful ones to inhibit phosphodiesterase 3 is your milrinone. Therefore, it helps in further retaining cyclical AMP and vasodilatation. Here, sildenafil works on phosphodiesterase 3. It's an anti-phosphodiesterase 5 inhibitor. This works on cyclical GMP, prevent it to convert into GMP. Therefore, it works as vasodilatation. So this is various mechanisms by which the smooth muscle cell works so that you're vasodilated. On the other hand, if you look at it, when we give nitric oxide along with oxygen on the right side here, this can result in peroxynitrate. Peroxynitrate is one of the powerful vasoconstrictor. Therefore, guys, don't keep giving too much of oxygen. Don't keep giving, maintaining PaO2 at a very, very high level because it can become detrimental also. On the other hand, if you look at it here, there is also endogenous endothelin 1, which is secreted. It is one of the body's most potent vasoconstrictor. So these are peroxynitrate and endothelin 1 will be counterproductive to your vasodilatory mechanism. That is how this slide becomes very important. I hope you're with me because I cannot see any of you and you cannot see me as well. So moving on, you know the pathophysiology, you know the causes, you know what happens after birth. Now we will swiftly move on to the management of pulmonary hypertension. The most important way that you manage pulmonary hypertension is one side, you decrease the pulmonary artery pressures, and on the other side, you increase the systemic pressures. How do you do that? By basically having a balance of these two. So the way that you reduce the pulmonary artery pressures is by having a fantastic lung recruitment. If you don't recruit, if you don't recruit your lungs, then basically your management fails. Whatever you do will not work if the lung recruitment is not good. And oxygen still stands one of the most powerful vasodilator in the world, what we've got right now. And followed by ventilation. Again, here, a lot of our babies will need ventilatory support because whether it's a meconium aspiration, whether it's a pneumothorax, whether it is congenital pneumonia, whether you're looking at birth asphyxia or congenital diaphragmatic hernia, in fact, majority of these babies are ventilated. And sometimes they need higher pressures as well to ventilate. Therefore, what we do is tend to use high frequency oscillatory ventilation in cases of babies needing significantly higher pulmonary pressures and higher ventilatory pressures. Also, your compliance can make it better if you start using a surfactant at the right time. That will work in improving the pulmonary compliance. Some babies will be very, very, moving a lot. You might have to use the sedation, and in some cases, you might have to give. In some cases, I think the slide is moving on its own. Abhishek, the slide started moving on its own. All right, so on the other hand, until I get my slides back, I don't know, I think Abhishek has taken the control. I'm so sorry, I think looks like there's a further technical glitch here. So I will just carry on thinking that you guys must be listening to what I'm saying. So when you look at reducing the pulmonary vascular resistance, some of the things that you use are oxygen, nitric oxide, and sorry, I'm just having a lot of technical issues here. Okay, so I got the control back. I'm so sorry. I'll just carry on again. So now, in order to increase your systemic pressures as well, you may need fluid boluses, especially if the baby has got sepsis, correction of acidosis in cases of severe acidosis. Even when you use the inotropes, it doesn't work that well, right? So in acidotic environment, our inotropes like noradrenaline might not function that well. And some cases you might have to use hydrocortisone also to improve your systemic blood pressures. And it's very important in Indian setup, especially there's a lot of pulmonary hypertension which happens due to sepsis, especially your gram-negative septicemia. So appropriate treatment of infection is absolute paramount, because in cases of sepsis, it will also impair your ventricular function by and large. So moving on, I just wanted to use this slide just to suggest that hypotension can be very refractory whenever you are dealing with pulmonary hypertension. And some of the causes of that would be capillary leak in cases of your sepsis, in cases of high intrathoracic pressures, especially when you're using the high frequency oscillation and the pressures are too high, it will impede your venous return and can cause hypotension. Then the systemic vasodilatation, again, as I said, it could be because of the usage of the drugs such as sildenafil, milrinone, or it can be because of sepsis in itself. Then you also have ventricular dysfunction because of sepsis, and all of this, my friends, will result in severe hypotension, and you need to be aware of that. Right, moving on to how do you treat these babies? Lung recruitment, as I said, forms the basis of how you need to treat these babies. Say, for example, I assume that the lungs are recruited. Now we go onto the left side. Say if your baby's blood pressures are normal and have a good cardiac function, then you assess how much is the oxygenation and how much is the CO2 level. If your oxygenation index is going more than 15 to 20, I would initiate nitric oxide. If your nitric oxide is not available, you should be thinking of shifting these babies to level 3 centers. On the other hand, sometimes we can use IV sildenafil. It is also available as an oral preparation, but IV sildenafil is what we normally use. But be careful, it can cause severe hypotension. Then on the other hand, if your blood pressure is normal, but cardiac dysfunction is present, especially we see in cases of severe birth asphyxia or in cases of where the sepsis is present, then milrinone is one of the best choices of pulmonary vasodilator, as well as it helps in increasing the venous return. Then the third wing is your blood pressure is actually low, but cardiac function is good. In these cases, it will be the beginning of it. Therefore, you can start some boluses. You can optimize your ventilation. You can use inotropes like dopamine. But my favorite in here is going to be norepinephrine or noradrenaline, especially if your pulmonary hypertension is driven by sepsis. In sepsis, norepinephrine works much better than any other inotropes, right? And also, if there is refractory hypotension, you can use hydrocortisone, and you should be able to start inhaled nitric oxide for these babies. The fourth wing is your blood pressure is also low, and if your heart is also not functioning well, you should assume that these babies will deteriorate rapidly, and these may be needing ECMO as the modality of the treatment. But on the other hand, until you win these circumstances, you need to be giving good fluid bolus, milrinone, because your cardiac dysfunction is there. You may need to use other inotropes like norepinephrine, sometimes vasopressin. I must admit, our experience in using vasopressin is very limited. Dobutamine can be used if it's predominantly your heart is not functioning well, because dobutamine works on your beta-1 receptors. And hydrocortisone, again, can be used, especially if you consider there is adrenal suppression, right? This slide depicts the overall usage of the antibiotics, usage of adequate fluid, good lung recruitment, and usage of appropriate inotropes and the vasodilators according to your blood pressure, your cardiac function, and also the volume status of the body. Okay, if everything else fails, you need to send the baby, consider the baby towards ECMO. Unfortunately, we have only about 3 or 4 centers for ECMO in the whole state. Right? Moving on. This slide depicts what happens in hypothermia. I won't dwell too much into this. Hypothermia on the left upper quadrant, if you see, asphyxia without even hypothermia in itself can cause pulmonary hypertension in almost 25% of the cases. However, if your hypothermia is very severe or deeper, your chances of developing pulmonary hypertension is more than 30%, right? Be careful in those circumstances. Also, there could be in utero hypoxia, which in itself can cause pulmonary vascular muscularization. Therefore, that will impair your nitric oxide synthesis and cause severe hypoxia, acidosis, and pulmonary hypertension, right? So moving on, what happens with oxygen? Oxygen, as I said, is the mainstay of treatment for pulmonary hypertension. On the other hand, if we give too much of oxygen, it will actually worsen your pulmonary vascular resistance, and because hyperoxia doesn't further reduce the PVR. It can also result in formation of the oxygen-free radical, as I suggested earlier. It can decrease your, cyclical GMP. It can worsen your function of the eNOS and, PDE5 activities. All of this further can result in vasoconstriction. Therefore, aim to keep your saturations around 90 to 95%. Also, aim to keep your pulmonary artery pressures, the PaO2s, between 55 to 80, and you start weaning down, right? So now coming to nitric oxide, very quickly moving on, I'll be talking about nitric oxide, what it is, the indications, when do you start, how do you wean, and what are the adverse effects. Hopefully, I will just take another 5 to 10 minutes in this. So inhaled nitric oxide identify as key endogenously derived factor as early as 1987. which attracted Nobel Prizes for 3 researchers in 1998. It is essentially a colorless, odorless gas, and it is soluble in water. It is available abundantly in environment, and it is usually produced by the combustion process as well as lightning. And in places, metropolitan places like Delhi, for example, the concentration of nitric oxide in the environment is very, very high. And in atmosphere, it presents in between 10 to 500 parts per billion. But as I said, if the traffic is very, very heavy, it can exceed 1.5 parts per million in those cities, Delhi, India. Somebody else who's talking there, can you please mute? And when you look at the exposure time, that's what we suggest to all our nurses as well as the doctors. You limit your exposure time to 8 hours or less, especially when you're using nitric oxide up to 25 parts per million, and your exposure to nitrogen dioxide should be less than 5 parts per million. So what we get is commercially available nitric oxide. It's manufactured by reaction of sulfur dioxide and nitric oxide, and reaction of sodium nitrite and sulfuric acid can also create nitric oxide, as well as ammonia over a platinum catalyst at a very high temperature. These are various ways commercially nitric oxides gas is prepared. So what are the effects of nitric oxide? The effect of nitric oxide can be on the lung parenchyma, where it acts to increase your growth of the lung parenchyma along with increase in the surfactant production. It might also work in the lung parenchyma by decreasing the elastin enzymes as well as reducing the inflammation. When coming to the bronchi, it usually increases the bronchodilation and decreases the airway smooth muscle proliferation in the bronchi. Coming to its effect in the vasculature, it usually causes increased vasorelaxation, also helps in angiogenesis. I hope you're all there with me so far. So what are some of the indications for using the nitric oxide? Generally, we use it for babies more than 34 weeks. I think there is already a talk which is coming up about nitric oxide usage in the preterm babies. And you start using nitric oxide when there is moderate to severe hypoxic respiratory failure. And you have optimized all the rest of the therapies as I suggested. Recruitment of the lung, good usage of the boluses, antibiotics, surfactant, and you have used inotropes and vasodilators. When all else have used to optimize therapy is still not working, then you're using the nitric oxide. And you generally start using nitric oxide between 15 to 25 oxygenation index. And OI of more than 40 if it is already there, that is an indication for ECMO. But you should try your nitric oxide first before determining to send a baby for ECMO. Some of the practical tips from my side is, if a baby is already on high frequency oscillation, you need to add 10 on top of your. And if the baby is already on 10 of, baby is already on nitric oxide, you need to add 10 more. For example, a baby is already started on high frequency oscillation and is on nitric oxide. And if the baby's oxygenation index is about 20, then your actual oxygenation index is 40 because you add 10 for high frequency oscillation and 10 for inhaled nitric oxide. That suggests OI of 20 in a baby on HFOV and INO is still extremely high. You should still consider this baby for ECMO therapy if the baby doesn't improve drastically. So there are various INO delivery systems that is available. What we use in our unit is called SLE Inosis, and there are other much better digitally, good, nitric oxide delivery systems that is available. In here, if you see, I'm sorry, it's switched off, but then there is a digital system here which gives you the amount of nitric oxide there in the cylinder, the amount of nitric oxide that is being delivered. For example, if you keep it at 20 parts per million, it shows 20. Then it also tells you how much is the nitrogen dioxide levels. Here on the right-hand side, you have the flow, which is 0 to 500 ml per minute, 0 to 100 ml per minute. There are two different jars for the flow. You use these knobs in order to adjust. There is a graph which you need to follow to adjust to achieve the level of nitric oxide that it is needed by you, whether it is 5 or 10 or 15 or 20. Moving on, some of the gas indicators. So if you see, there are two dials here. One of the dial is to say what is the pressure in here, which is in the bars. Then the other dial is there, which suggests how much of nitric oxide is present in the cylinder. And the black one here is your regulator. So if you look at it closely, one of the dials is suggesting the pressure in the nitric oxide system is about close to 2 bars. The inside one is your bar, 1, 2, 3, 4, and then the outside one is your PSI, which is again pressure in a different values and system. So if you look at it, you need at least 1 bar pressure to for your nitric oxide input that should get into the SLE system. So this is the back end of the SLE nitric oxide delivery system. You look at it here, there are 2 canisters that is provided. One is nitric oxide canister, and the other one is your NO2, nitrogen dioxide canister. These canisters are used in order to calibrate your nitric oxide system. So there is a green color, the pipe or a catheter is available, which you should connect to the nitric oxide output and the input areas, and therefore if you calibrate, it becomes 0. Once it is 0, then the machine is calibrated. Then you go on to calibrate individually nitrogen dioxide. Once you calibrate it, if you see the display in here, it shows NO2 span done, continue. Then you need to attach the other canister, which is your nitric oxide, and it should say nitric oxide span done, continue. So that suggests both nitrogen dioxide and nitric oxide are calibrated. Without calibrating, you cannot use the nitric oxide system. Then you have what is called as the nitrogen dioxide scavengers here on the left side, the black ones, and the whole nitric oxide circuit. I'm so sorry, I did not want to open the circuit. I should have shown this to you, but then these are expensive. That's why I did not open the circuit. Then this diagram is available in majority of your equipment setups. So here, if you look at it, there is a ventilator, then there is a INOS system. It can be any other nitrogen or nitric oxide delivery system. So if you look at the left side most is your dangling structure, which is your scavenging filter I showed you. And there is a bacterial filter attached to the ventilator. Then there is an inspiratory and an expiratory limb of the ventilator. Your nitric oxide tubings should be connected to the inspiratory wing of your circuit, that goes there. And then there is another catheter which is connected near the ET tube, which will actually measure the amount of nitric oxide delivered, and it will also tell you the amount of nitrogen dioxide that is exhaled out, right? So that will be displayed in the nitric oxide system. So extremely important you have your biomedic available when you're setting up these sort of circuits, which is very complex. What we can also do is keep making sure that you keep giving training to the nurses about how to set up this nitric oxide system. All right, moving on very quickly, dose and response. I would normally start at 20 parts per million, and rarely we need to increase it to 40. If 20 is not working, 40 will usually not work as well. Then more and more, if you use a higher concentration, then the toxicity is higher. And the response you should see is by increase of your PaO2 by 10 to 20 millimeters of mercury, and subsequently decrease in your oxygenation index. This is the response you will be seeing. So every time 4-hourly or a 6-hourly blood gases, arterial blood gases that you do, make it a point to measure the oxygenation index. If you measure oxygenation index, you will know whether you are winning the situation or whether you're actually losing. So if you look at this diagram again, hats off to Dr. Satyan to come out with these kind of diagrams. Whenever you start initiation of your inhaled nitric oxide, we apply a 20-20-20 rule, where you start nitric oxide when oxygenation index is 20 or above. You use a dosage of 20 parts per million, and the response is suggested by increase in the pressures, partial pressure by 20 parts per million, 20 mmHg. So this is 20-20 rule in terms of initiation of the nitric oxide. When you come to weaning of the nitric oxide, you follow 60-60-60 rule, where every 60 minutes you start weaning after demonstrating a very good response to nitric oxide. What is that response? Your oxygenation should be less than 60%, and therefore your PaO2 should be showing at least about 60 millimeters of mercury, or your saturations are showing at least about 90%. So when you initiate INO, you follow 20-20-20 rule. When you are weaning the INO, you follow 60-60-60 rule. Again, come back to here in this slide. When you've initiated the inhaled oxygen, you should see, come on to the left side, you should see a complete response. What is a complete response? It means your PaO2 is good, your saturations are good, and your FiO2 should be less than 60, right? Then what you should do is you should start weaning your nitric by 5 parts per million every 4 hourly until you reach 5 parts per million. Then you should wean even slower than that, going by 1 part per million every 4 hourly, and then you discontinue. How do you know if you have successfully weaned? Your oxygenation and your saturation and your PaO2 should be stable even after discontinuation. If this doesn't work, coming to the blue picture here, then you have to restart your nitric and then start from where it has worked. Then you start weaning it down. Coming to the right side of this diagram, there are no responders or partial response. That is when you should revisit and say, is my diagnosis correct? Is there any other congenital cyanotic heart disease? Or the ventilator, is it delivering correctly? Am I recruiting the lungs properly? Did I use the right inotrope? Did I use the right vasodilator? And when you used all these things, and if still there is no improvement in your PaO2 or your saturations, then you may need to discontinue or even consider ECMO as the further management in these babies. Okay, I know this is a very busy slide, and I hope I've done some justice. Just remember, initiation is 20-20-20 rule, weaning is 60-60-60 rule. All right. Very quickly moving on, adverse effects of the nitric oxide. If you see here, nitric oxide beautifully gets into the smooth muscle cell. With the help of the guanylate cyclase, it converts your GTP into cyclical GMP, which helps in the relaxation of smooth muscles. But on the other hand, here on the right side, this is the alveolus, and you're giving nitric oxide along with oxide being a lipophilic agent. It nicely diffuses into the endothelial cell. What happens here? It meets its friend, hemoglobin. Hemoglobin is the one which carries your oxygen to all the parts of the body. But then nitric oxide can combine with hemoglobin and forms what is called as the methemoglobin. So methemoglobin is in a reduced form of hemoglobin, and its oxygen carrying capacity is actually less. Therefore, that is one of the toxic substances released by using nitric oxide. The second substance that is important is your nitrogen dioxide. What does nitrogen dioxide do? It causes further lung damage by releasing the free radicals. So nitric oxide in very good amount is very helpful, but you have to also remember that it can cause adverse effects. So in this slide, it shows the NO2 should be less than 1 part per million, and you should be using a good scavenging system on your ventilator in order to remove the nitrogen oxide coming onto the environment. And your methemoglobin should be less than 5 is okay, but ideally I would keep it less than 3, because if it's going more than that, your oxygen carrying capacity will be reduced. And nitric oxide can also worsen your bleeding time. How? It can impair the platelet aggregation and therefore worsen your bleeding time. And when you stop the nitric oxide, unfortunately, sometimes you can develop pulmonary hypertension, which is rebound. Are there any contraindication for usage of nitric oxide? Yes. If there is a congenital heart disease, duct-dependent lesion, you don't use it. Or if there is a TAPVD, if you have inadvertently not diagnosed it, it might worsen your pulmonary edema. And therefore, echo is extremely important to establish your pulmonary hypertension and rule out structural cardiac conditions. And keep lookout of your methemoglobin levels. If it is going above 5, I would start reducing the nitric. On the other hand, if it is going about 10, I think Dr. Abhishek mentioned this at the beginning of the talk. If it's going about 10, I would even stop the nitric because you will only make it worse. Just 2 minutes of evidence. I won't bore you much. There's quite a lot of evidence available. Lovely studies have been conducted right throughout the world. This is one of them, the neonatal inhaled nitric oxide studies, or famously called the NENO study. I've summarized the result here. INO reduced the risk of death by 120 days, or by day 120, sorry, or the initiation of ECMO is reduced from 50% to 30%. So it definitely works. And also, death or ECMO in the controlled group was about 64% as compared to 46% in the INO group. And the risk ratio is about 0.72 with a good confidence interval between 0.57 to 0.91. So this NENOS trial definitely showed benefit. Moving on, NENOS trial also included congenital diaphragmatic hernia, where 76% of them had pulmonary hypertension. But initiation of nitric was above 40. Therefore, they did not see any difference in the primary outcome, which is death or usage of or surgery. But it is also shown better stabilization before the surgery and increased entry to the surgery for these babies with CDH. But here, my friends, if you look at it, they have started at OI of 40 and above. But what we generally do in my unit, if we know beforehand, I would normally put these babies on ventilation with high frequency oscillation. And as soon as my oxygenation index is hitting 15 and above, I would initiate the inhaled nitric oxide. Because as we see, if oxygenation index is very high at the time of you starting, then it doesn't work that well. Moving on, the Singri trial, which was a double-blinded, randomized controlled, multicentric trial, 186 babies recruited in this with severe pulmonary hypertension. The primary outcome was known to be reducing the need for ECMO and the death. So the death was decrease in the death 38% in the INO group versus 64% in the control group. So when you look at the systematic review of the inhaled nitric oxide, it significantly improved the outcomes in term and near-term infants. How? By decreasing the combined endpoint of death and the need for ECMO. It's a combined endpoint, okay? And this was due to reduction in the usage of ECMO, and the number needed to treat was very good, 5.3. But if you look at the individual variations, INO did not reduce the mortality or the length of hospitalization, but it's in a combined endpoint of death and the need for ECMO, it was very, very beneficial. It also suggested, INO did not reduce the need for ECMO in infants who had unrepaired CDH. However, I will always suggest start a nitric oxide in babies with diaphragmatic hernia as soon as your OI starts hitting 15 and above. Don't wait until it becomes worse. Sometimes PPHN can be very refractory to inhaled nitric oxide. There are only 2 more slides. Up to 40% can be non-responders. In those circumstances, you have to look at why it is not responded. Sometimes we know it is because of reduced response to guanylate cyclase, reduced expression and activity of GC, and increased clearance of cyclical GMP by phosphodiesterase enzymes. And sometimes it is structural, severe pulmonary hypoplasia. secondary to CDH, or severe oligohydramnias for such a long periods of time, you cannot help because there is muscle hypertrophy and you will have pulmonary bed which is very, very hypoplastic. So in these cases, PPHN will be refractory. The only thing that you can do is try ECMO in these circumstances. And two examples that I would like to share here. During the COVID season, we were very busy when we used nitric on 3 babies. One of the first cases, term baby boy, LSCS meconium aspiration, which means there is a maladaptation. And this baby, unfortunately, had birth asphyxia and needed total body cooling. So there is not just a double whammy, there is a triple whammy as well. This baby presented to us with severe pulmonary hypertension and on high frequency, and the baby needed inhaled nitric oxide for 3 days. Coming to the case 2, again, it's a baby with loss of fetal movements for about 4 hours. Scans showed moderate high drops, and the baby developed severe hypoxic respiratory failure after it was born, and this baby had a significant cardiac dysfunction. Again, this comes under the pathophysiology of maladaptation. Unfortunately, the baby's hemoglobin was only 5 at the time of delivery. And when we did the KBT test, the Kleihauer-Betke test, we knew that the diagnosis was a severe chronic feto-maternal hemorrhage. The third interesting case, first of it, what we used in a preterm baby was in the COVID season. Again, it's a preterm 25 weeks gestation, no liquor volume at all from 22 weeks gestation. The baby presented with severe hypoxic respiratory failure, which worsened very, very quickly. And the baby was on inhaled nitric oxide for 4 days and then gradually weaned. And while we weaned the baby, we used sildenafil to gradually wean. And then we started sildenafil oral as well. This baby went on to need bosentan on top of it. I did not discuss much about these drugs, which will be dealt in detail later by another speaker. And this baby is currently doing very well, 35 weeks of gestation in just 2 liters of HFNC and in 21% of oxygen. Coming to my last slide, you should have a very high degree of suspicion of development of the pulmonary hypertension. It's very difficult to look after because the blood pressure and the pulmonary arterial pressures are very, very labile. It just changes quite a lot. Therefore, consider adequate type of ventilation, for example, high frequency oscillation, and you have to recruit the lung, in which case you might have to use a surfactant and you might have to use a good type and modality of ventilation. And you need to treat your underlying condition, whether it's a surfactant deficiency, whether it's an infection, or whether you're using the vasodilators or whether you're using the inotropes. But most importantly, if things are not going well, I would revisit from the basic. Get the echo done. I know a lot of you are doing bedside echoes. Guys, in these circumstances, echo by an expert cardiologist is extremely, extremely important. And it goes without saying, establish central lines in managing these very, very difficult babies, because you'll be needing very frequent gas to calculate the oxygenation index. You need central lines to administer inotropes. Without central lines, please don't administer inotropes. If you don't have a UVC, at least you need to go for a peripheral PIC line and peripheral arterial line if you don't have a UAC. And in my experience, we have won a lot of cases by early starting of nitric oxide, and I then generally will have an inclination, and we start from 15 OI onwards. And you also have to think that if nothing works, ECMO is also there as a modality of management. Thank you very much for patient listening, and I'm so sorry we had